Hola, hola. Bueno, vamos a empezar el simposio que hoy vamos a tener ahora el simposio de Aleph Medical, a quienes agradecemos el apoyo para realizar esta actividad. Y la conferencia que va a ser sobre la neurología de la esclerosis tuberosa, epilepsia, cognición y conducta, ¿sí? Que va a estar a cargo de la doctora Elizabeth Thiele, ¿sí? La doctora Elizabeth Thiele es de Estados Unidos, es neuropediatra, epileptóloga y actualmente se desempeña como directora del programa de epilepsia pediátrica del Massachusetts General Hospital y también es directora del Centro de Esclerosis Tuberosa del Carl James Escort Center y profesora de neurología nada más y nada menos de que la Escuela de Medicina de Harvard. Y hoy tenemos la suerte de tenerla con nosotros para hablar sobre este tema. La doctora Elizabeth Thiele ha hecho numerosos aportes y recientemente ha hecho un gran aporte siendo la primera autora e investigadora principal del estudio de cannabis y esclerosis tuberosa, que la verdad que nos ha aportado mucho conocimiento. Así que bueno, agradecemos a la doctora Thiele por estar con nosotros y le damos la bienvenida para el inicio de su conferencia. Muchas gracias, Elizabeth.
Thank you very much for the very kind introduction and also for the invitation to join you at the meeting. I always enjoy talking about tuberous sclerosis complex, which has been a big focus of my career. So these are my disclosures, and I'd like to start by telling you about my friend Michael. When Michael was 4 years old in 1960, very normal child, a little bit rambunctious 4-year-old boy, but the mother became quite concerned about these bumps that appeared on his face. And went to the pediatrician, and the pediatrician actually was concerned that Michael may have leukemia and sent him to the hospital. The hospital, they were able to make the correct diagnosis that he had tuberous sclerosis complex based on the facial angiofibroma, as well as the forehead plaque. And otherwise, Michael was fine. Michael was followed then every year due to the diagnosis of tuberous sclerosis complex. He had had no seizures, no other difficulties. And then when he was 12, his mother called again the pediatrician that Michael had flu-like symptoms, that he was vomiting, complaining of headache, but had no fever. The neurologist knew that having tuberous sclerosis complex, that Michael very likely had a subependymal giant cell tumor, and so brought Michael to the hospital. That was prior to CT scans and prior to MRI scans. So Michael had a pneumoencephalogram to identify which side, which ventricle the tumor was in. And by the time that was identified and Michael had surgery, due to the increased intracranial pressure, as well as the surgery, following the surgery, Michael had a dense hemiparesis, cognitive difficulties, as well as epilepsy. I met Michael first when he was 40, and kind of his journey with TS did not stop with that SEGA. But during his life, he had renal involvement necessitating a nephrectomy, and over the years lost the ability to ambulate for reasons that were uncertain, and also continued to have refractory epilepsy. But even with this journey, Michael still really wanted to have a full life. And Michael is now in his 60s and doing very well and has now been seizure-free for many years. So with Michael in mind, what I'd like to do today is first give a brief overview of tuberous sclerosis complex, discussing how it has multi-system involvement, and then turn to focus on TSC in the brain. Then we'll look at what we are learning, focusing on epilepsy and TSC, both with regard to the natural history as well as treatment, and the relationship of the epilepsy to the cognitive profiles, autism, and mental health issues in TSC. And then at the end, kind of turn to what we need to know, what causes seizures in tuberous sclerosis complex, And how are all of these neurologic symptoms related? So first, what we know about tuberous sclerosis complex is it's not really rare. We think the incidence is now about 1 in 5,500 to 6,000. We know that it is an autosomal dominant disorder, although 2/3 of the cases are sporadic without a family history. And we also know there are two genes, the TSC1 gene and the TSC2 gene, both identified in the 1990s, and a mutation in either can cause an individual to have TSC. We're able to identify mutation in TSC1 or TSC2 in 85% of individuals who meet clinical criteria for tuberous sclerosis complex. And we know that mutations in TSC2 are much more common than TSC1, and that overall mutations in TSC2 have a more severe phenotype. We also now know that of those that we have been unable to identify a mutation in TSC1 or TSC2, many of those no mutation identified patients have TSC as a result of low-level mosaicism of either the TSC1 or TSC2 gene. We know that TSC is a multi-system disorder that can affect most organ systems. And we also know that there's wide phenotypic variability, including within families. Within a family sharing the same mutation, one individual may be severely affected and one individual may be mildly affected. And we do not yet understand the reasons for that spectrum. We also know that gender somehow matters, such as LAM or lymphangioliomyomatosis, the main pulmonary involvement in TSC, would affect almost exclusively women and not men. And importantly, about 20 years ago, we learned that TSC1 and TSC2 were components of the Mtor signaling pathway. This is a very simplified cartoon of that pathway, but very important when we learned that TSC1 and TSC2 are upstream from the Mtor protein and effectively inhibit the Mtor protein. If a mutation happens in one of these genes, Mtor activity is upregulated, leading to the various manifestations that we see in tuberous sclerosis complex. In 2012, a group of us got together to look at the diagnostic criteria, and TSC continues to be a clinical diagnosis, now also including gene testing. But as we said, multi-system involvement with almost every organ system being involved. TSC2 still is defined by definite TSC by the presence of two major criteria, and we'll look at those, or one major and two minor features. We also do consider the diagnosis of possible TSC important, since many of the manifestations of tuberous sclerosis can appear at different times during an individual's life. So an individual has possible TSC if they have one major feature or two or more minor features. Looking at the major features, and again, as you can see, these involve multiple organ systems with both the brain and the skin, which are the two most affected organ systems, both involved in about 90% of individuals with TSC. Both of them having multiple major features. Therefore, if a child went to a dermatologist thinking they had facial acne, and the dermatologist noted that they were actually angiofibroma, and the dermatologist also noted several hypopigmented maculas, then that dermatologist in that office that day could diagnose that individual with definite TSC. Similarly, if a child comes in with a new onset seizure and a CT scan or an MRI demonstrates cortical dysplasias, tuberous and subependymal nodules, then that day that child can also be diagnosed with definite TSC. Performing the complete clinical evaluation is also very important to document which organ involvement each individual has in order to monitor people to optimize their health. The minor features are things that are seen frequently in TSC, but are not as specific to TSC as the major features, but also involve several different organ systems. Turning then from the overview of TSC to focus on the brain, CNS involvement is really a hallmark of the disease and is seen in about 95% of affected individuals. The pathologic features which we'll look at include cortical tubers, subependymal nodules, subependymal giant cell tumors, and radial migration lines. This is an axial MRI image of an individual with TSC. And as you can see, scattered cortical tubers with a high signal. And then in the wall of the ventricle, this darker nodule representing a subependymal nodule. So cortical tubers are located at the gray-white junction, and they vary widely in size and in distribution. Histologically, they're areas of dysplasia with marked distortion of cortical lamination, dysplastic, hypomyelinated aggregates of abnormal glial and neural elements, with the glial-derived cells and astrocytes predominating. And tubers are also characterized by giant cells, which are enlarged, bizarre-appearing neurons, or large cells with both neuronal and glial characteristics. And the neurons in tubers lack axons and normal dendrites. This is a pathologic specimen of a brain of an individual with TS, and as you can see, here's the cortical ribbon, and then you see disruption of the cortical ribbon where the cortical tuber is. Different from tubers are subependymal nodules, and these are seen in about 90% of individuals with TSC, and these are located around the wall of the lateral ventricle. They most commonly occur at the caudothalamic groove in the vicinity of the foramen of Monroe. And these occur either as discrete or roughly confluent areas of firm hypertrophic tissue and have been referred to in the past as candle gutterings. Histologically, these are also distinct from tubers, and subependymal nodules consist of astrocytes, which arise from the subependymal zone and protrude into the ventricle. And for reasons we do not understand, they calcify by puberty or early adulthood. And these are generally asymptomatic, but can develop into subependymal giant cell tumors in up to 20% of individuals. Subependymal giant cell tumors, also referred to as subependymal giant cell astrocytomas, present during childhood with a median age of presentation of 9 years, a range typically from 1 to 21 years, and there are a few case reports in the literature of these presenting in older individuals in their 30s. These are derived from the subependymal nodules in the lateral ventricular wall, and the symptoms are consequent to increased intracranial pressure, headache, vomiting, papilledema, as my friend Michael experienced, or also increased seizure activity. Treatment up until recently has been surgical, removing the subependymal tumor. But as you know, everolimus was shown to be effective, Mtor inhibitor was shown to be effective in reducing the size of the subependymal giant cell tumors, and now is FDA approved and approved elsewhere in addition to the United States. And what I've become quite respectful of over the years is that the presentation of these may be very subtle, sometimes with changes in behavior, sometimes with changes in appetite. And so we monitor individuals very closely if they have these subependymal nodules to make sure that they're not developing and becoming clinically significant. And this is an example, another MRI scan showing a subependymal nodule, a subependymal giant cell tumor in the right anterior horn of the ventricle in the region of the foramen of Monroe. So you can see this individual also has some subependymal nodules in the posterior horns bilaterally, which have already calcified. And I believe that by the time they calcify, they have lost their growth potential and have stopped growing. Then this is an image of one of our patients who had a subependymal giant cell tumor that extended into his third ventricle, which would have made resection quite difficult without him requiring a VP shunt. And this young man has now been on rapamycin for about 10 years, controlling the size of that tumor. Then with the recent consensus conference, what was added to the neuroanatomic features were the radial migration lines or radioglial lines. And you can see here as several on this individual. And the significance of these is not really certain, but again, recognized as a feature seen in TSC. So turning then from the anatomy of TSC to the clinical symptoms and neurologic symptoms of TSC. Epilepsy is very common in individuals with TSC and is the most common symptom occurring in 85% of individuals. The onset is typically in the first year of life, with approximately 70% of individuals developing seizures during infancy, and 1/3 of children with TSC will develop infantile spasms, making it the highest single cause of infantile spasms. Interestingly, 1/3 of those children with TSC who develop infantile spasms go on to have a normal cognitive outcome. And we and others have been trying to figure out the variables involved in outcome from TSC and infantile spasms. What we've known for many years is if children with TSC do develop infantile spasms, vigabatrin is particularly effective and should definitely be used as first-line treatment. When we looked at the natural history of TSC several years ago in our population, we found that 2/3 of individuals with TSC will develop medically refractory or intractable epilepsy, twice as common as in the general epilepsy population. But also importantly, in our patient population, we found that over 1/3 experienced long-term remission, including up to several decades of seizure remission, and 40% of those were off anti-seizure medications. And I think this is very important because it's not unusual for me to meet a new patient with TSC who has been told, or the family's been told, that they will need lifelong anti-seizure medication due to the seizures and having TSC. So the treatment of epilepsy and TSC in 2022 and beyond, anti-seizure medications remain first-line therapy. Seizures in TSC are focal in onset, so most medications could work. There is anecdotal experience on the efficacy, particularly of newer drugs, but there have been no controlled comparison trials. As we said, vigabatrin is clearly the drug of choice for infantile spasms in TSC. But we know that vigabatrin does have possible side effects and toxicity, including retinopathy. And we also know that it can result in MRI signal change, increased signal in the deep gray nuclei, which we think overall is not clinically significant. And over the past few years in tuberous sclerosis community, there's been an interest, evolving interest, on is there a role for prophylactic treatment? So what if medications don't work? Dietary therapy, both the classic ketogenic diet, as well as low glycemic index treatment, which we developed at the MGH about 20 years ago, have been shown to be effective in individuals with TSC. There have been several reports on the role of vagus nerve stimulation, which can be beneficial. And we also know that epilepsy surgery plays a very important role in the management of refractory epilepsy and TSC. But over the past several years, there's been incredible interest and now data on what about the role of Mtor inhibitors in the treatment of TSC, and what about the role of cannabidiol. And also, as with other rare genetic disorders, there's also increasing interest and work being done on developing genetic therapeutic approaches, both for the management of epilepsy as well as the other symptoms and manifestations of TSC. So first, looking at the role of Mtor inhibitors, and this was everolimus with the EXIST-3 trial. This trial enrolled 366 TSC patients, ages 2 to 65 years, with treatment-resistant epilepsy. Importantly, both this trial and the cannabidiol trial we'll talk about enrolled adults, which is very important because a lot of people view the efficacy of these medications perhaps best in the pediatric population. So the results from these trials showed these medications are also effective in adults living with TSC. To be eligible for the EXIST-3 trial, individuals had to have 16 partial seizures during an 8-week baseline. And then they were randomized 1:1:1 to placebo, high exposure, or low exposure. And the design of the trial included a 6-week titration, followed by a 12-week maintenance. And this trial did meet its primary endpoints, both with regard to responder rate, or those having a greater than 50% reduction of seizures As you can see, is 15% responder rate in the placebo, low exposure, 28%, and the high exposure of 40% of individuals were responders, having a greater than 50%. The FDA prefers median reduction in seizures or change in seizures. And as you can see, both the low exposure and high exposure also met the endpoint for that, with the low exposure showing about a 30% mean reduction in seizures and the high exposure almost 40% reduction in seizures. The most common adverse events in this trial were very similar to the other mTOR inhibitor trials in TSC, including stomatitis, diarrhea, vomiting, nasopharyngitis, upper respiratory tract infection, pyrexia, cough, or rash. And this trial led to the FDA approval in April of 2018 of everolimus for TSC-associated partial onset seizures in adults and pediatric patients 2 years and older. Now we'll turn to the cannabidiol trial, which, as in the introduction, this has been a large part of my past 8 years, is really trying to characterize the role of cannabidiol in the treatment of refractory epilepsy, including in TSC. And this is the publication that resulted from this trial. This trial enrolled 244 TSC patients, ages 1 to 65 years, with treatment-resistant epilepsy. These individuals, to be eligible, had to have greater than 8 seizures during a 4-week baseline. And then they were randomized 1:1:1 to placebo, or a low dose of CBD being 25 milligrams per kilogram per day, or a higher dose, 50 milligrams per kilogram per day. And importantly, as I mentioned earlier, about 25% of those enrolled in this trial were adults. And the trial design of this was a 4-week titration, followed by a 12-week maintenance. And the primary endpoint of this trial was the percentage change from baseline in the number of TSC-associated seizures. And as you can see here in this graph, both doses in this trial did meet their primary endpoint, with statistically significant greater reduction in seizures compared to placebo. The adverse events in this trial were very similar to the other trials with CBD or Epidiolex, being diarrhea, vomiting, constipation. We also did see in this trial that there were elevations, mild elevations of liver functions. Again, the majority of these patients were on concomitant valproate, and none of these were clinically significant. Some individuals had decreased appetite. Somnolence was seen, which was often due to drug-drug interactions with other medications, particularly clobazam, and cough. And this trial led to the FDA approval in 2020 of purified cannabidiol for the treatment of seizures associated with tuberous sclerosis complex in patients 1 year of age and older. So importantly, this trial showed the efficacy of cannabidiol in focal seizures, because that's the question I commonly get, because the earlier trials in Dravet syndrome and Lennox-Gastaut syndrome wasn't necessarily clear to many people. Did that mean this was a medication that was effective for focal seizures? So the tuberous sclerosis trial showed that it was. It also extended the age of approval for Epidiolex or cannabidiol down to 1 year of age. Then turning to the concept of is there a role for prophylactic treatment? And there have been 2 trials investigating this, one in Europe, which has been published, and another in the United States, which hopefully the results will be available soon. So looking at the European trial, which was called the Epistop Trial, this trial enrolled 94 infants with tuberous sclerosis complex without a history of seizure. These infants were diagnosed either by a family history, by the presence of cardiac rhabdomyomas, or by skin features. So diagnosed with TSC prior to developing seizures. These infants had monthly EEGs, and vigabatrin was started after the first electrographic or clinical seizure, or after the identification of epileptiform activity. So the moment that EEG showed any abnormalities in the form of epileptiform activity, these patients were started on vigabatrin. And 54 patients started on vigabatrin prior to seizure onset, 27 randomized and controlled trial, 27 open label trial. And the reason for that is some of the countries had different ethics committee decisions on having open label versus randomized control. What was seen in this trial was that the time to the first seizure was longer in those who had vigabatrin preventative therapy. With the randomized controlled trial, 364 days to first seizure versus 124 in those not treated, and the open label 426 days prior to the onset of the first seizure versus 106 in those who did not receive vigabatrin therapy. And what was seen at 24 months after enrollment is that the preventative treatment reduced the risk of clinical seizures, drug-resistant epilepsy, and infantile spasms. So suggesting that we are able to modify the course of tuberous sclerosis complex by preventing the epilepsy. But then taking a step back from the epilepsy, I think all of us realize that for individuals living with TSC, it is not just the seizures. And we and others have spent a lot of time characterizing that the presence of refractory epilepsy, as well as infantile spasms and TSC, is significantly associated with cognitive impairment, autism spectrum disorders, and psychiatric disorders, including self-injurious behaviors, as well as sleep disorders. This is a study we did several years ago, and others have shown similar results. At that point, we had 107 of our patients had neuropsychological testing. And what we found that the demographics of those who had neuropsych testing were very similar to the overall clinic group, except that the study group had a younger age and spasms were much more common. But what we found was what has been seen is that there's bimodal distribution of cognition in TSC, with roughly a 50-50 split between two modes, meaning that 50% of individuals have normal cognition and 50% have some degree of cognitive impairment, which is often severe. When we looked at characteristics, we found that those that had the higher IQ, that cognitively normal, had an older age at seizure onset. In fact, of patients with seizure onset greater than 2.5 years of age, none had significant cognitive impairment. We also found that those with familial TSC were more likely to have normal cognition, although that population was higher TSC1 and a lower frequency of infantile spasms and refractory seizures. We found that risk factors for cognitive impairment included current seizure activity, refractory seizures and mixed seizure types, as well as a TSC2 mutation. We also have looked, as have others, at autism and TSC. And this is a study we published several years ago, during which we had a single neuropsychologist who evaluated our patients. And she found that 40%, or 41 of 103, met criteria for autism spectrum disorder. Those with autism were significantly more likely to have a TSC2 mutation, were significantly more likely to have a history of infantile spasms and refractory epilepsy, were significantly had lower IQ or cognition. Interestingly, were not more likely to be male, suggesting another sex difference in TSC, as in the general population, autism is 4 times as common in males as females, or boys and girls, and that is not true in TS, where it's 1-to-1. And we did not find a significant difference in TSC brain-related involvement. When we looked at the relationship of autism to anatomic features, we found no significant difference between the regional distribution of the largest size tuber or of the overall tuber burden, what volume of the brain was incorporated with tuber. But we did see that there was a trend for those TSC patients with autism to have their largest tuber burden, but not necessarily the largest tuber in the left temporal lobe. We also found no difference between cerebellar tubers, calcified tubers, radioglial bands, or subependymal nodules. But we did find that those with autism were had a significant higher incidence of cyst-like tubers, which we've been trying to characterize over the past several years. Does the genetic mutation matter in autism and TSC? We found that there were fewer TSC1 mutations in the TSC autism group than in our individuals with TSC who did not have autism. And as I mentioned previously, we found TSC2 mutations were very common, present in 90% of those with autism versus 59% without. We did not see a significant difference regarding the mutation type or if the mutation was truncating or non-truncating, but we did see a possible relationship of autism and a mutation in the Hamerton interaction domain of TSC2, as that was seen in 28% of patients with autism compared to 5% without. And this possible relationship is so far one of the only hints at some more specific genotype-phenotype correlation in TSC. Looking at the relationship of autism to epilepsy, we found that epilepsy was more common in those with autism. A prior history of infantile spasms was more common. Earlier age of seizure onset seemed to play a role, greater seizure frequency, and a higher incidence of refractory epilepsy. So clearly, epilepsy does matter in autism and TSC. We also looked at EEG features and found the EEG had greater epileptiform features in those with autism, particularly in the left temporal lobe. Then a lot of our focus over the past 15 years has been on the mental health issues of TSC, which we've been very happy to see are becoming playing a much more important role, both in the clinical care of individuals with TSC, as well as research efforts. And as you may know, there's now an acronym for these, TAND, or TSC-associated neuropsychiatric disorders. And we found that these are very, very common. When we looked at this, 66% of our patients had at least one psychiatric symptom, and over a third had greater than one symptom. The most common being mood disorders, anxiety, ADHD, aggressiveness, and disruptive behaviors. We found that adults with TSC were much greater risk of psychiatric disorders than the general population. And this was with a validated questionnaire called SCL-90. And the main difficulties adults with TSC we found have interpersonal sensitivity, social alienation, depression, and cognitive performance. Then, as I said earlier, we've also found that self-injurious behaviors are common in TSC, occurring approximately 10%, often significant. And these are highly associated with the TSC2 mutation, history of infantile spasms, seizures, cognitive impairment, and autism. Other aspects we've seen regarding mental health is we noticed several years ago that post-traumatic stress reactions are not uncommon in individuals with tuberous sclerosis complex, and they can often occur following what most would consider mild stressors. And these can significantly impact the individual's ability to function. Many of my patients have really had tremendous changes in their level of functioning and ability to perform tasks of daily living with this post-traumatic stress. We find that these typically respond to SSRI, and is there a role for beta blockers, which are often used in treating PTSD. And I think what anyone in the TS community would agree is that anxiety in individuals with TSC is almost universal. It's an obsessive type of anxiety where people will frequently worry and focus about specific things that can change over time. And I find that even today, even with an appreciation of TAN and increasing awareness, anxiety in individuals with TSC is extremely underappreciated, underdiagnosed, and undertreated. Then an area we've been interested in over the past several years and are trying to study now is we also have several TSC individuals who are savants. Even though their overall cognitive functioning is borderline, IQ 60 to 70, they have areas where they have specific expertise. One of my patients knows everything about the US presidents. We have one of our patients who, with no formal instruction, taught herself perfect Spanish and then perfect French. And we have some of our patients who can put together 1,000-piece puzzles very quickly, and also some people with fairly impressive artistic abilities. And we're trying to study this to better understand that aspect of having TSC. So what we have learned with tuberous sclerosis, and I think what every individual living with TSC and their family knows, is when you look at the neurology of tuberous sclerosis complex, it is not just the seizures. As we've seen, the presence of refractory epilepsy and infantile spasms in tuberous sclerosis complex is significantly associated with cognitive impairment, autism spectrum disorders, psychiatric disorders, and sleep disorders. Therefore, those of us in the TS community, both the medical community and especially the patient community, feel that it's really crucial to control the epilepsy. Hence this thought of early, more aggressive treatment and hopefully prophylactic treatment. So with that overview of epilepsy and TSC and where we are, what do we need to know? We do not know why individuals with TS develop epilepsy. We think the tubers are somehow involved, but are the tubers themselves epileptogenic, or do they irritate the neighboring neurons? Also, are all tubers created equally? Many individuals, most individuals with TS have multiple tubers, and yet the epilepsy usually only comes from one. So are some tubers more epileptogenic than others, and why? Or could epileptogenicity be related to diffuse and or more subtle cortical or subcortical abnormalities? I have one young adult with TS with highly refractory epilepsy that even on a 3 Tesla brain MRI, we do not see definite cortical tubers. And then importantly, are particular individuals with TSC at risk for seizures and at risk for infantile spasms? So there is a lot of work both in our group and groups worldwide trying to really understand what the relationships are when you look at the neurologic aspects of TSC between the tubers, seizures, interictal discharges, the genotype, and could there be a role of haploinsufficiency, something just about having TS, regardless of where your tubers are, how many you have, could that be playing a role, particularly with regard to the anxiety and the other aspects of TAND? So trying to understand the relationships of the anatomic features, the physiologic features, the genetic features to what we see clinically, the cognitive difficulties people may have, the behavioral psychological issues, as well as autism. So I started telling you about Michael, and I'll finish telling you about Sarah, showing the gains that we have made in our ability to understand TSC and provide better care. I met Sarah when she was a few days old. She was born in Western Massachusetts, having hundreds of clinical seizures on day of life 1. And in retrospect, her mother really thinks Sarah likely had onset of seizures in utero. Sarah was transferred to us due to her epilepsy. A scan showed that she had tuberous sclerosis complex. And for the first 5 weeks of Sarah's life, we were unable to do anything to control her seizures. She was discussed every week at the epilepsy surgery conference. We knew her focus was right frontal. We knew she had a tuber there, but everyone at that point was very hesitant to perform epilepsy surgery in a neonate due to the potential morbidity. But by 5 weeks of age, we had done nothing to improve Sarah's seizure control, and she had had numerous medication trials. So Sarah had epilepsy surgery. This is Sarah at about 10 months of age. A little difficult to see here, but subsequent to the surgery, she has had a mild left hemiparesis. And this was Sarah a few years ago. Since Sarah's surgery, she has been seizure-free. She does have the left hemiparesis. And over the years, she also has dealt with other aspects in her road with TSC, including renal involvement that we're monitoring with angiomyolipoma. She developed significant anxiety that was very centered on her parents' safety and had difficulty with them leaving the room. And although she is now a high school graduate and is attending college classes with her goal to write a novel about a young girl living with TSC who has left-sided weakness and falls in love. So with that, I'd like to thank everyone. The Herscott Center at MGH has grown over the years to quite a large clinical program. We are celebrating our 17th anniversary this year, and we now have 46 different specialists affiliated with the program, providing care to both children and adults with TS. As I tell patients when we see them, our youngest TS patient has yet to be born. Our oldest is turning 96 this year. And kind of in addition to the clinical program, we have a very active clinical research program. And so I'd like to thank the people who have worked hard with us over all the years, trying to better understand not only the neurologic aspects of TSC, but the other aspects as well. So thank you all very, very much for the invitation and for letting me share with you our experience with TSC.
Muchas gracias, doctora Elizabeth Thiele. Creo que pasó muy rápidamente, pero por todos los puntos importantes y actualización excelente en su charla. Así que le agradecemos. Y bueno, vamos a pasar ahora a las preguntas.
Hola, bueno, vuelvo. La primera pregunta es, los pacientes menores de 1 año que ya tienen el SEGA y que no va progresando clínicamente, ¿qué recomendación dan? Ya que el everolimus no sería una opción y la cirugía sería por ahí demasiado cruenta. ¿Cuál es la recomendación de ustedes en cuanto a cada cuánto repetir la resonancia? Bien, esa es la primera.
So that's a very good question. And in the United States right now, we actually do have a clinical trial that's enrolling for cannabidiol in infants with TSC less than 1 with refractory seizures. So hopefully that will be an option soon, safety and tolerability. And there is also interest in TS, not just with regard to epilepsy, but the other aspects of TSC of early use of Mtor inhibitors. So people are also looking at that. Again, not only efficacy, but safety and tolerability. Other than those options, we are pretty aggressive about trying to get seizure control in infants with TSC, knowing that they're going to have such incredible impact on all other aspects. And we do epilepsy surgery in children less than 1 if we're unable to get the seizures controlled. Other than the everolimus and CBD, there's no specific data for efficacy of our medications in TSC, but we've had very good luck with many of them, including clobazam and lacosamide. The other thing that can be quite effective and can safely be done in children less than 1 is the ketogenic diet, which can be extremely effective in controlling seizures in TSC.
Y la segunda pregunta, perdón, la segunda pregunta es si tiene alguna consideración acerca del estudio que hizo Eamon y colaboradores acerca de la metformina en la esclerosis tuberosa, sobre todo como anticonvulsivante, que vieron ellos como resultado secundario, no fue lo que buscaban, pero vieron que había un efecto positivo en cuanto al control de convulsiones.
That's a good question. I don't really have enough knowledge of that trial to really address that. But, there was interest in the consideration of metformin. particularly kind of if you look at LAM. There was a lot of interest many years ago with LAM in women. Would metformin be an effective treatment? So that's the nice thing about the TSC scientific community, is many people are taking now a step back from the Mtor inhibitors, saying we know what they do in TS, but what other treatments could be effective in addressing different symptoms or manifestations of TSC? And I know there's interest in metformin as a possibility.
Thank you.
Hola, excelente charla. Mi pregunta es, si, ¿en qué dosis usa la vigabatrina en la profilaxis y cada cuánto hace el electroencefalograma en pacientes sin crisis?
So I'm not sure what the dose of the trial was for the Epistop trial or for the ongoing trial in the United States, but clinically how many of us are now using vigabatrin, because most of the TS programs in the United States now, if a baby is identified as having TSC prior to the onset of seizures, most of us are doing an EEG at least every month for the first 6 months, sometimes longer. And then if a child does develop abnormalities and we decide to start vigabatrin, the dosing would be the same. I think we typically would titrate up to 100 milligrams per kilogram per day. There was a lot of debate over those trials to use vigabatrin or some other treatment, since vigabatrin is very good for infantile spasms in TSC, but I'm not sure it's any better than our other anti-seizure medications for the focal seizures. But the trial for the Epistop trial did show that the use of vigabatrin resulted in a significantly lower incidence of spasms. So I think as we move forward thinking about, gee, there is a role for prophylactic therapy, I think hopefully we'll be hopefully able to identify which is the best. I've always been very interested in trying the ketogenic diet as a preventive therapy, because I think the efficacy and safety and tolerability of it is quite good, and it can be very effective in controlling both infantile spasms and focal seizures.
Hola. Esto es más una pregunta de orientación que otra cosa. Llega a la consulta de nuestro servicio de enfermedades poco frecuentes una señora de 50 años con un tumor de Koenig, nada más. Es enviada por dermatología, pero a su vez cuando abre la puerta de la consulta aparece su hijo de 35 años con signos de retraso mental o retraso cognitivo y algunas conductas compatibles con autismo. ¿Estudiaría usted a la madre o arrancaría estudiando al muchacho?
The question to see if they could have tuberous sclerosis complex, or they do have
Para nosotros no tenía tuberosclerosis, pero tenía el tumor de Koenig y la dermatóloga afirma que es patognomónico de tuberosclerosis. Pero no tienen todos los criterios mayores. ¿Estudiaría usted a la mamá o al hijo?
I think that's a very good question. And I guess I'd want to know what more the mass on her neck is, because I don't know of any mass on a neck that's pathognomonic for TSC. But I think that what I'd probably do is take a look at both of them closely with regard to the skin features, since the skin's involved in 90%. And by both of their age, if they're going to have angiofibroma, they should be present. The periungual fibroma should be present. The shagreen patch should be there. And then it depends on what kind of evaluation the boy has had, because if he does have neurologic, issues, then a brain image might be really helpful. In the United States now, we're getting luckier with gene testing. For a while, we had a lot of trouble getting insurance reimbursement, particularly for adults, but that is changing. So I don't know what the situation is for, in your country, if the genetic testing is available with these gene panels. But good question. I think you could start with either, but I would be really interested to know what the dermatologist thought was pathognomonic of TS.
Sí, buenos días. Yo quería saber si... ¿no? quería saber si los trastornos conductuales se trataban solamente o se atribuían solamente a la epilepsia y por lo tanto controlando la epilepsia se mejora el trastorno conductual, o si se utiliza además alguna medicación como sertralina o risperidona en estos pacientes, y cuál hubiera sido la mejor respuesta en estos casos.
So another really good question. So it is definitely true that for many of my patients with TSC who have behavioral dysregulation, if we get the seizures improved, the behavior improves. But there are also many people with TSC who have significant behavioral issues that do not have epilepsy. So even though they can be confounding, I think that they're separate for many patients. And even our patients with epilepsy, sometimes getting the seizures controlled does not really greatly benefit the behavior. So to answer your questions, yes, we actually have a psychiatrist who works with us. And I think that that's what there's a big push in the TS community to raise the awareness that the mental health issues are so significant and so prevalent that there needs to be more attention paid to them. And we are now compiling the experience of our psychiatrist who has seen over 200 patients with tuberous sclerosis complex. Both with what diagnoses he's made, what medications he's found effective, and any possible genotype, phenotype. We do have a lot of success with SSRIs, particularly with the anxiety. And we also do find, the psychiatrists, that many patients respond to benzodiazepines, even though they are always hesitant to prescribe these and use these long-term. For many people, they just appear to be effective. We also do have many children who are on Risperidol. We have some of our patients on Abilify, because the spectrum of mental health issues in TS is very, very broad. From I might have very significant anxiety, or I might have really significant mental health issues, either self-injurious behavior or aggressive behavior, or mania or bipolar. So I think that I feel as an epileptologist that managing the mental health issues is almost out of my league. I think I really need the more specialized psychiatric care to do so if possible.
¿Qué tal? Mi pregunta tiene que ver con la dosis de cannabidiol en adultos, siendo que el trial es a partir de 25 miligramos kilo día, 25 y 50, y muchas veces los que hacemos epilepsia en adultos nos encontramos con pacientes de más de 100 kilos de peso. En ese caso, por una cuestión de acceso a la medicación, sabiendo que es muy costosa y es difícil de que las prepagas u obras sociales la cubran, y por otro lado, en la cantidad de medicación que tienen que tomar, si tiene experiencia con dosis menores en adultos y cuál es la eficacia para sus crisis, por un lado, y por otro lado, relacionado con la pregunta que acaba de contestar, si piensa que el cannabidiol podría tener un efecto en controlar otros aspectos que no sean solamente la epilepsia, sino las cuestiones conductuales, por ejemplo.
That's a really great question. And, I have been very involved with the development of cannabidiol, Epidiolex in the United States. So I've had patients on this now for over 8 years. Because we were part of the expanded access program that preceded the clinical trials in Dravet and the clinical trials in LGS. As you know, the clinical trials that led to the approval for Dravet syndrome and Lennox-Gastaut syndrome were lower dosed, 10 milligrams per kilogram per day and 20 milligrams per kilogram per day. And efficacy was seen at those doses in those trials. And then the TSC trial, I think what it showed us is not necessarily that the higher dose is better, but it did show us that some patients do benefit from the higher dose, and that the tolerability, even though there were more adverse events at the higher dose, the tolerability was still pretty good. So when we start any patient on TS, on CBD, adult or pediatric, TSC, Dravet, or what other epilepsy, we basically start at 5 milligrams per kilogram per day and wait and see. Because we do see, like many of our anti-seizure medications, there's a very broad dose range of efficacy. And one of my adults with a focal epilepsy, highly focal refractory epilepsy that was not a surgical candidate, he has been seizure-free at 2.3 milligrams per kilogram per day now for 3 years. We also do find that for many patients, the combination, even though CBD can be very effective on its own, the combination with clobazam can be really beneficial for many patients. And then there's not a one size fits all, because some patients do best with the lower dose of CBD, a slightly higher dose of clobazam, and vice versa. So it's a titrating either the CBD kind of on its own or the CBD with other anti-seizure medications to find what's the most effective dose. My adult who's at the dose of 2.3 milligrams per kilogram per day, we titrated him much higher. He was in our expanded access program. And if anything, we thought his seizures may have gotten worse at that higher dose. But we all felt when he first started it, we thought he benefited. So we slowly started titrating down on the dose. And once we hit that dose, he's been seizure free. So it makes it maybe a little bit more difficult to use because you have to figure out who's I can't look at a patient and say, this is a patient who's going to do well with a low dose, or this is a patient who's going to need a high dose. But that's kind of not so dissimilar, especially in pediatric epilepsy, with the way we treat patients with our other anti-seizure medications. So important to know there's a broad dose range. Some patients will do very well. And if I had a 100 kilogram patient, I absolutely would start them at that lower dose, because the other concern with the higher doses is in part due to the olive oil formulation, and I mean sesame seed oil formulation, and in part due to the CBD is the laxative effects. And we know that those become more significant with the higher doses.
Doctora, buenos días. Muchas gracias por su presentación. Mi pregunta es acerca de si tiene información o nos puede brindar información acerca del uso de la ganaloxona, un modulador alostérico positivo de los receptores GABA, que sé que hay trabajos ya en fase 2 y 3. Ganaloxona, un modulador del receptor GABA para las crisis focales, principalmente en TSC1. Si tiene algo de información.
Oh, yes, I do. I'm sorry, Genexilum. Yes, I do. So Genexilum basically is being developed. It's now in clinical trials in the United States for seizures associated with TSC. There was a phase 2 study, small study, that showed that it was effective at reducing seizures. I don't remember the exact percentage reduction, and was well tolerated. So the results from that small study were encouraging enough that Marinus Pharmaceuticals, the company developing ganaxolone, is now doing clinical trials. And as you may know, ganaxolone was recently FDA approved in the United States for seizures associated with CDKL5 deficiency, being the first FDA approval for CDKL5. So I think we're all pretty excited to see, will it also be an effective medication for tuberous sclerosis? Because even though I'm pretty excited about CBD, and also, you know, the everolimus does also have a role in treating seizures in TSC, there's still an unmet need. You know, the majority of my patients are still having seizures, so we still need more medications that are effective, safe, and well tolerated.
Bueno. Muchísimas gracias, doctora Thiele. Excelente sus comentarios y aprendimos muchísimo con usted hoy. Así que bueno, la esperamos en algún momento en vivo aquí en Argentina. Así que bueno, muchas gracias. Un aplauso nuevamente.
Thank you very much. Everyone have a good day and hope to see you in Argentina soon. Thank you.
Bueno, les anunciamos que a partir de ahora no hay más traducción simultánea por hoy, así que le pedimos que devuelvan los equipos de traducción a la gente de técnica y reiniciamos a las 14, ¿no? 14 horas.